Sir, shall we start now, sir?
Yeah, one sec. Yeah, hi.
Yes, sir. So good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So the topic for the day is urinary tract infections and women's health. So I welcome all the participants and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. And now it's time to introduce our eminent speaker for the day, Dr. Ankesh Saithya, sir. Sir has completed her MBBS from Padma Shri Dr. D.Y. Patil Medical College, Navi Mumbai, and sir has undergone training, ultrasound training course in basics obstetrics and gynecology at Chikista Sonography Center under Dr. Aniruddha Badit. And sir has also completed his fellowship in advanced laparoscopy at Evo Hospital, Ahmedabad, Gujarat, under Dr. Deepak Limbachia. And doctor has performed more than 200 diagnostic laparoscopic and laparoscopic tubal sterilization procedures in various BMC hospitals. So with this introduction, I welcome you, sir. Sir, before going to session, I would like to take 1 minute of your time for introducing our Shield Connect web page, sir. So this is our Shield Connect web page where you can find more scientific informations available in our website. We have also a separate column for blogs. So most of the doctors love to share their research and thoughts and advice through blogs. Sir, I request you to share any one or two blogs to post in our website, sir. If you are interested, you can just share any blogs of topic of your own interest, sir. And we also have a page for webinars. So all our webinars are conducted through our Shield Connect web page. So you can find the details of upcoming webinars and the past webinars, which is available in our website. We have the details of all the webinars which we have conducted in the last 1 year, and we have a separate page for the speakers. So all the detail of the speakers are available in our Shield Connect web page, and we also have another page for PCOS awareness. So you can find lots of videos of from doctors speaking about their opinion about PCOS in various vernacular languages in India. And we also have a page for our leaders. So you can see more than 220 leaders, doctors who are our key opinion leaders who are supporting this Shield Connect web page through their webinars and scientific informations. I welcome, I request the participants to go through our web page and make use of it. Thank you, sir, and over to you, sir.
Thank you so much. Can I share my screen?
Yes, sir.
All right. So hi guys, thank you for introducing me. Thank you Venkateshan. Thank you Dr. Stalin. And I'd like to start. This is me, Dr. Ankesh. Nothing to say. I just want to start the talk. So basically this is how, for basic anatomy, this is how the kidneys look, the ureter and the urinary bladder entering into the urethra. As you can see, this is a sample of urine microscopy showing what the bacteria look like in the urine cells. So UTI is very common. It was first documented in 1550. The Egyptians called it sending forth heat from the bladder. Basically, this is how old a disease has been there from the times of history of medicine. So basically, it could be symptomatic, asymptomatic. It's very dangerous to have ABU, which is asymptomatic bacteriuria, which infection in the bladder, prostate, pyelonephritis. Although we as gynecologists are seeing UTI more commonly in females, we'll come to the reasons of that more. But nothing has worked more in UTI than antibiotic therapy is what we have been learned to believe. So basically, the most common one is asymptomatic cases, which are 10 to 13%. Acute bladder pain, cystitis comes in 1 to 4%, although it's much higher now. Pyelonephritis is when the kidneys are infected. It can get worse over there. And incidence is higher in pregnant women than non-pregnant women by complete 40%. There is a rate of recurrence definitely seen in UTI in people who get it. And mostly we see a single bacterial species, at least 80% are uncomplicated cystitis, and pylo are due to the bacteria called as E. coli, most common. The other less common but often we see in practice are Klebsiella, Proteus, Enterobacter. In hospitals, acquired UTI, a variety of organisms can be seen like Pseudomonas and Staphylococcus. UTIs caused by Staph aureus are usually because of the hematogenous dissemination. Group beta hemolytic also has been seen in pregnant women. Now, what are the factors that increase urinary stasis? Having a kidney stone or a tumor, any obstruction due to a tumor or fibroid, retention in a neurogenic bladder, impairment. Basically, what is important to understand is that whenever there's stasis of urine, urine is not coming outside the body. That's what happens. Also, having renal calculi, having a catheter for very long in any cesarean patient or any patient who's had a surgery like hysterectomy or any abdominal surgery, gynec surgery, catheter remaining in the bladder for very long is a nidus for infection for sure. Also, any defect leading to any defect in the genital tract, shorter female urethra, obesity, fistula can lead to it. Also, with increased age, having HIV, having diabetes mellitus is a definite reason to have UTI. Now, what are the other disorders? Now, basically, now constipation also is a problem. Voiding dysfunction can be seen, but most common we see it because of multiple sexual partners, pregnancy, poor personal hygiene, menopausal state because of low estrogen, use of spermicides in the lubricants used by the male partner, less water intake, and not flushing urine for a long time, not passing urine for a long time. So, what are the risk factors? We'll come to the broad classification of risk factors. The drugs which cause the iatrogenic causes, the hospital-induced causes are uses of antibiotic. Many patients, they self-prescribe themselves or they go to the GP and they just use the same antibiotics over the years, not recommended. Using spermicidal jellies can cause UTI. Indwelling catheter in the bladder for a long time can cause. Behavioral problems, basically any sexual intercourse, could be a recent STI, STD, any voiding dysfunction. Also, people having in excessive, the vesico-ureteral reflex is when the urine flows back from the bladder up to the ureter. This is a very common cause. In the female sex, of course, in females, it's common because of the smaller urethra and the familial tendency. Very often, we see patients who have kidney stone, patients who have problems in families, they are prone to UTI. Also, vaginal infections, vaginal mucus properties can cause ascending infections and harm the urinary area and cause a UTI. This is very commonly seen. So what are the bacterial entry sites? Understanding this is very, very important. How do the bacteria enter the urinary tract to cause infection? The 4 possible modes into the genital tract. It is generally accepted that the periurethral bacteria ascend the tract most. So what they are seeing, the bacteria outside the vagina on the lining of the urethra can enter the urinary tract most easily. Most cases of pyelonephritis are caused by ascent of bacteria. Basically, any bacteria from the anal area or the vaginal area can ascend. This is the ascending infection, can enter the bladder to the ureter and up to the kidney parenchyma. So if you look at this diagram, you see my mouse, this is the infection route from ear to ear, then ear to ear and ear to ear. So basically the whole thing starts with colonization. Then it goes from the urethra to the bladder and causes uroepithelial penetration. Using the bacteria, use their fimbriae and attach to the bladder over here. Then the bacteria ascend, go up the ureter and cause infection in the kidney caused pyelonephritis. If this continues, if there's any obstruction with the ascending with a kidney stone, there could be a concomitant kidney stone along with a UTI, then this is going to cause acute kidney injury. So what are the parts most commonly affected? Now, kidneys, the affection is called as acute pyelonephritis. The patient typically comes to you with upper back pain. Typically, we have a younger female walking in or a female walking in with lower back pain or loin pain. Fever might not be there, but will be there if it's a pyelonephritis. Definitely, it will be fever with chills, and she will have nausea, vomiting. Most commonly seen is number 2, which is the bladder cystitis. Patients coming with lower abdominal discomfort with pressure, painful urination, and very often hematuria. Urethra or urethritis is the reason why patients exactly come to the doctor in the first place, which is burning while passing urine. Now, what are the clinical manifestations? Either because of bladder storage or bladder emptying. The symptoms are divided into 2 parts, emptying symptoms and storage symptoms. What are the emptying symptoms? Weak urinary stream, hesitancy, intermittency, post-void dribbling, urinary retention or incomplete emptying with dysuria. Now, how do we ask the patient? Difficulty starting the urine stream results in delay in between initiation and urination by relaxing the sphincter. So basically, the patient goes to the washroom with the urge to pass urine, but from the urge till actually passing urine, there's a longer gap. Number one, interruption of the urinary stream, very, very irregular, very, very patchy stream, intermittency, post void dribbling, urine loss after complete voiding. The patient has gone to the washroom, emptied the bladder, but again she complains of urine loss after emptying her bladder. Inability to empty urine from the bladder, which can be caused by atonic bladder or obstruction of urethra, can be acute or chronic. This is a major problem if she has retention. Dysuria is the painful feeling and the burning while passing urine. Frequency is very simple to understand, 8 times or more in 24 hours period. Urgency, a sudden, strong, or intense desire to void immediately, accompanied with frequency. Incontinence, involuntary or unwanted loss of leakage of urine. Nocturnal, waking up 2 or more times at night because of need to urge to void. This is very disturbing for the patient's sleep. And nocturnal enuresis, complete loss of urine while sleep, very commonly seen in children, also called as bed wetting. Urine collection is the main to diagnose it. Always ask the patient to give a midstream clean catch. Very important to explain to the patient what a midstream clean catch means. Also very important, if she is a catheterized patient, then also a catheterized specimen could be from the urine bag. STD is suspected, a urethral swab for STD testing is obtained prior to voiding. Okay. Acute onset of urinary symptoms. Now, what are the main symptoms? Dysuria, which is the painful burning of urine, frequency, excessive passage of urine more than 8 times 24 hours, and urgency, can't wait. So basically, how do we tackle it? If a healthy woman is not pregnant, she's low risk for multi-drug resistant. Consider urine, no culture is needed. Consider telephone management, especially in these pandemic times. History or risk of STDs, you have to do a urine analysis and a pelvic examination. If it's a male patient with perennial pelvic or prostatic pain, please consider a detailed urology evaluation and urine culture analysis. Patient with the catheter, always remove the catheter or change it, do a culture and do a urine culture. Other patients, basically what you can suspect is you can do a urine analysis, urine routine will do a culture and check for any anomalies, like any problems, like any genital problems, bladder defects, vaginal defects. Again, this is a very intense slide, but the whole idea how to manage a patient. Now, acute onset of backache, nausea, vomiting, fever, you have to label the patient and consider what they need. But mostly, depending on the severity, I would recommend a urine culture. Blood culture only if there's fever, older patient, immunocompromised, things like that. Again, consider ASB. You can screen the patient. According to me, urine culture and blood culture would be the first two to think of in bad UTI with fever. Now, what is the differential diagnosis where it could be something else but not UTI? There's something called as the acute urethral syndrome, which occurs only in women. It's a syndrome involving dysuria, pain, frequency. It's called the dysuria pyuria syndrome. It resembles cystitis. However, in urethral syndrome, urine cultures are usually negative. So this is a very common diagnosis we see in our clinic in Mumbai, where a patient, we suspect the patient surely has UTI and she complains of severe burning, but the urine reports come absolutely clear, nil for bacteria. So it's a combination of dysuria, pyuria with pain. Urethritis, the possible cause is because of chlamydia. This is a typical STD. Chlamydia trachomatis and ureoplasma urolithecum, which are never seen on urine culture. You can do a blood culture and treat them symptomatically for fever. Other causes are urethral stenosis, requires dilatation. Pelvic floor muscles requires again evaluation. Atrophic urethritis seen in women above the age of 70-75 because of severe menopausal symptoms. Any trauma because of any surgery or any external blunt injury. How do you manage a case? So uncomplicated UTI, I would say use the antibiotic. My first choice is nitrofurantoin. This is the older combination of ceftriaxone. Acute, adequate fluid intake. You have to tell the patient to consume at least 10 glasses of water a day. That's 3 liters of water a day. So very important. You can use an analgesic like phenoxypyridine or combination agent. Counsel the patient for recurrence and reduction factors. Just 1 minute. Yeah, hi, am I audible?
Yes, sir. Yes, sir.
Sorry for the small interruption I had. Yeah. So antibiotics are required. So outpatient, you can treat with the oral antibiotics. Following criteria satisfied. Patients are expected to be adherent. Patients are immunocompetent. Patients have no nausea or vomiting or evidence of volume depletion or septicemia. Patients have no factors suggesting complicated UTI. The antibiotic is Ciplox 500 milligrams twice a day for 7 days post meals. The second option is Ceftran for 14 days. Now, what about UTI in children? So basically, depending on the age of the child, if the child is less than 3 months and temperature is above 38 degrees, you can do a urine culture and give the according antibiotics. From 3 months to 3 years, 3 months to 3 years above 38 degrees temperature, again I would specify that if it's UTI specific symptoms, again a urine culture is important. Depending on the culture, you can decide antibiotics, and same for the kids above 3 years. What about non-pregnant patients? Consider empirical treatment with antibiotics for otherwise healthy women aged less than 65 years presenting with severe 3 or more symptoms of UTI. Explore alternative diagnosis. Consider pelvic examination of women with vaginal itch or discharge. The urine dipsticks guide treatment to otherwise healthy women under 65 of age presenting with mild under 2 symptoms of UTI. Antibiotic treatment for lower UTI is do not treat non-pregnant women of any age with antibiotic. Treat non-pregnant women of any age with symptoms or signs of acute LUTI with 3-day course of nitrofurantoin. Care should be taken to which prescribing for elderly because of increased toxicity. Take urine for culture to guide changes of antibiotic for patients who do not respond to Ceftran or nitrofurantoin. Now, what about pregnant women? Very important. So, standard quantitative urine culture should be performed routinely at first antenatal visit for every patient. Confirm the presence of bacteria in urine with second urine culture. Do not use dipstick for diagnosing bacterial UTI at the first or second visits. Any patient with asymptomatic bacteriuria, please treat the patient with antibiotics. The why UTI is more common in pregnancy? The answer lies in the physiological changes occurring in the UTI and pregnancy. Now, basically, what happens is there are changes in the urinary tract. Those changes only cause more of UTI. Now, what happens is increased axillarity, increased tenderness in the organs, more blood supply, increasing in the vascular lining of the mucosa. All this causes more UTI. The kidney size increases, dilatation of the calyces, stasis of urine because of pyelonephritis, increase in GFR and renal flow rate, increase in renal flow rate, changes in the pharmacokinetics of drugs and treatment. Just a minute. Huh? Dr. Stalin,
Yes, sir.
give me 5 minutes. Huh?
Yes, sir. Sure, sir.
Yeah. Can I join back? Yeah.
Yes, sir.
So basically, why do these changes occur in pregnancy that cause more UTI? Very simple. The growing. So basically, what happens over here is the uterus grows in size and it has direct compression on the ureter, plus the effect of progesterone causing the kinking and the lengthening of the ureter. There is also structural changes giving rise to hydroureter because of a dilated ureter, more stasis of urine, and more chances of UTI. Due to persistent pressure of the gravid uterus, there is thickening of the bladder trigone. Also, the bladder pressure increases from 8 to 20 centimeters of water. Due to the above reason, the significant vesico-uteral reflex during pregnancy causing ascending UTIs. Now you can see this is a beautiful description of what exactly pregnancy does to the ureter and the kidney. So how do you treat a patient in a pregnant woman with UTI with antibiotics? Always take a sample of urine routine. Give a 7-day course of any of the following antibiotics. given the risk of urine bacteria and pregnancy can cause preterm labor, at least 7 days of antibiotics is recommended according to the guidelines. For men, you can are generally complicated because of the anatomy or the instrumentation. Conditions like prostatitis, chlamydia, epididymis should be considered. Antibiotic again, they should be able to penetrate the prostatic fluid. Quinolones, Ciplox, Martifur, cephalosporins. Treat UTI with a quinolone. Refer men to urology department. Always be sure. Do not rely on the classical clinical symptoms for signs of predicting likelihood of symptomatic UTI. Signs and symptoms compatible with catheter-associated UTI include new onset of worsening of fever rigors, altered mental status, malaise, lethargy, flank pain, costovertebral angle tenderness, and acute hematuria. Criteria for selecting antibiotics in UTI. The drug should be present in high bacterial lethal concentrations of a blood, all fluids of urinary tract, glomerular filtrate, interstitial space, intercellular space, all the areas, so that the antibiotic is effective against all bacteria present in all parts of the system. No residual infection persists even after the cessation of antibiotic therapy. Drugs should not be altered in its efficacy, detoxified by the liver and kidney itself. Drugs should not be nephrotoxic, very important. Drugs should be present in the same bacterial lethal concentration in urine while passing down the ureters and stored in the bladder for a long time. What about recurrent UTI? Repeat urine analysis, culture, sensitivity, a good antibiotic course for at least 5 days, sensitivity guided antibiotics, urinary analgesic like phenazopyridine combination agent, cranberry or lignoberry juice should be used, adequate fluid intake, imaging study of the urinary tract and selected cases. Okay. Diagnosis of complicated UTI. The pathogens are usually E. coli, enterococci, pseudomonas, and staphylococci. The choice of antibiotic is fluoroquinolone, aminopenicillin, third genus cephalosporin, aminoglycosides. So what are the main things? Maintain hygiene. Hand wash is so important. Wipe front to back in a female. Clean the urinary meatus while having a bath. Wash clothes well. Use liquid soap. Urinate before and after intercourse. Wear comfortable, clean clothing. Consume a healthy diet. Stay hydrated. Avoid caffeine. So conventional treatment is for burning, micturition, pain, and recurrence. You require an alkalizer, flavoxide, and cranberry, which is all there in the UTI flush preparation. It goes to UTI flush. So the pain component, the dysuria component, and the recurrence is all taken care by the ursolic acid, which is an anti-inflammatory agent, analgesic. Very, very good for like an NSAID, comparable to an NSAID. Potassium, magnesium citrate, cranberry extract, active ingredient PAC, and D-mannose. UTI flush, as you see, it's an excellent component, and I would recommend anyone to use this for a bad UTI. Thank you.
Thank you, sir. Thank you very much for those wonderful presentations, sir. It's always an honor to hear you, sir. Sir, if you allow us, then we can go for the questions, sir. If there is any questions in the chat box, I will read it for you, sir. So the first question is, what is the duration of antibiotic treatment for acute uncomplicated cystitis, sir? Sir, I request you to unmute, sir.
Very good question.
Yes, sir.
My first choice is always to go for a 5-day course of tablet nitrofurantoin, 100 milligrams twice a day for 5 days.
Sir, what are the single dose antimicrobial therapies for UTI, sir?
I would use the following combination of the powdered preparation of phosphomycin sulfate. You get a 1-day regimen of phosphomycin sulfate, 3 grams of phosphomycin sulfate in a glass of 300 ml of water to be taken overnight and not to pass urine at least 4 to 6 hours after consuming it.
Okay, sir. So when should hospitalization to be considered for UTI, sir?
Now, suppose a patient is having excessive, she's having symptoms of hematuria, uncontrollable UTI. She's having symptoms of, very, very bad dysuria, acute blood in the urine, then I would consider to hospitalize her and give her IV fluid and give her antibiotics after taking a urine culture. I would hospitalize such a patient for bad UTI with almost very bad pelvic pain, loin pain, with the following symptoms I mentioned. She's for definite hospitalization.
Thank you, sir. And the next question is, how do rates of UTI differ in postmenopausal women, sir?
So basically, a woman with postmenopausal symptoms, she'll definitely have, she'll have a severe menopausal symptoms, vaginal dryness, atrophy. She'll have the full vaginal dryness. She'll have severe UTI. She'll have low estrogen. So you have to take care of the vaginal dryness with the estrogen supplements. You can give her oral tablets of estrogen, tablet Premarin, or the better preparation is give her local application of E3, estriol cream in the vagina. Helps a lot in vaginal dryness and UTI and postmenopause.
Okay, sir, we have another one question like, what types of complicated UTI can develop in patients with diabetes, sir?
Again, very simple. You can have even ABU, asymptomatic bacteriuria can develop definitely in someone with diabetes. And if the patient doesn't have very high diabetes, she can also, be treated in the same way. Otherwise, very high diabetes can develop vaginal infections, genital infections with a UTI. So she require to treat with higher antibiotics. You can use a combination of augmentin, which is a combination of amoxicillin and clavulanic acid along with the urinary antiseptics, and take care.
Thank you, sir. And we have another one, last question, sir. What factors increases the risk of antimicrobial resistance in UTI, sir?
Yes, very good question. So if somebody has been self-treating themselves and using prolonged antibiotic course, I repeat, prolonged antibiotic course without a doctor's prescription, without urine culture, they get resistant UTI. Also, if they've been taking antibiotic course and leaving in between because they get better, that can definitely cause resistance.
Okay, sir. I don't find any other questions in the chat box, sir. So if you allow us, then we can end the webinar for today, sir.
Thank you.
Yeah, thank you. Thank you very much for being with us and spending your valuable time with us, sir. And hope the participants find this webinar useful for them. And I would like to thank them for their active participation, sir. On behalf of Shield Healthcare, I would like to thank all the
Yeah,
colleagues of our company for making this possible for this webinar.
I want to thank Venkateshwar. I want to thank you, Dr. Stalin.
Yes.
I have my patients. I have Lucy. I have Priyanka Chechani. I have Griva Shah and Richa Daroch, who were there today, and Nikita Bhatia. So I want to thank them for attending this seminar along with the organizers. Thank you.
Fine, sir. Thank you, sir.
Bye bye.
Thank you.
Thank you.